I think the main orthopedic encounter with neurofibromatosis, primarily type 1, is leg length discrepancies, bowing, scoliosis. And at the end, I get a lot of questions about medical radiation. So I have a few slides about medical radiation because that seems to always be a really hot topic. But as we know, part of the diagnostic criteria for neurofibromatosis are distinctive bone lesions. So we do see bone problems in a substantial percentage of people with NF. And pseudarthrosis or bowing of the tibia or ulna, dystrophic scoliosis, and then sphenoid wing dysplasia, which is the face, which I don't know much about, are the characteristic lesions or diagnostic lesions. I have a colleague that we've seen a handful of the ulnar pseudarthroses, and this was on the chat box before we came in. And at least in our hands, the ones that we have seen have typically need some form of reconstruction or treatment to try and get that pseudarthrosis to heal and not be painful. What I most commonly see, I think the most common reason I'm seeing an NF patient is a limb length discrepancy, which is incredibly common. About a third of the population has a difference of up to ½ an inch. And patients with neurofibromatosis can develop a limb length discrepancy. There's a variety of ways to treat this, and there's a variety of reasons to come in early because there are specific treatments we can do during childhood that once the growth plates are closed, the child is no longer a candidate for that. So here's a patient with NF who had a leg length discrepancy. Again, the cool thing about treating children is that they're growing and changing, and every time I see a child back, there's new developments, and I get to know them as a person as they mature into adolescence. But they do have a growth plate with a unique structure. It's a little stripe of cartilage at the end of long bones. And these are cells that replicate, and that makes the bone grow longer. So in peds ortho, we can manipulate those structures to the advantage of the child. And we treat everybody from the 5-day-old to the 15-year-old, which is a very different skeleton, as you can see. So for this particular child, he had a difference that we anticipated was going to be close to 2 inches when he was done growing. So we time it. So he has about 2 years of growth remaining. And then we shut down the long leg and let the short leg catch up. And it's outpatient, and he can go home the same day. And then over the course of the next 2-3 years, those legs are going to equalize themselves. This is a lot easier than being an adult and having to go in and shorten a leg where it's a surgery and you can't put weight on it for 6 weeks and you're on crutches, and it's a much bigger deal. So we do this as this kind of bread and butter peds ortho, and we wait a couple years, and his leg length discrepancy now is kind of improving. You can only do this when you are very close to being done growing, because once you shut down a growth plate like that, it's not going to grow anymore. And so it has to be timed. So again, I'm often seeing patients at regular intervals, checking their leg lengths. If it's less than a centimeter, less than ½ an inch, we don't care. But if it's getting close to that 1 to 2 inches, then there's treatments. There's a whole nother host of treatments for very severe leg length discrepancies, which are much less common with NF. So in really young children, once in a while, we'll encounter a person that has a pretty significant leg length discrepancy, like I think we have a case here. So 7-year-old, he's got about a 2-inch leg length discrepancy already, very active in sports and running and jumping, and family feels like it's bothering him. Like most kids, he's not interested in wearing a shoe lift. And so he had a little bit of bowing on one side that we corrected with this little plate that tethers the growth plate. And then after that, we had a discussion. I said, hey, we can wait till you're 13 and then slow down the longer leg with an outpatient surgery. Or if you want to correct it now, we can do 2 outpatient surgeries. And he said, hey, I don't have like being off like this. I want to do sports. I want to be more active. So we did a little guided growth procedure. We slowed down the long leg, and 3 years later, now he's equal, and we're taking out the plate on the long leg. So some people don't like these because who wants to touch the normal leg, or who wants to touch the long leg? So that's the downside. You know, it'd be better to have a way to speed up the short leg, but we don't have that yet. And it'd be better to have a drug or an injectable rather than a surgery, but we don't have that yet. But in the future, I hope we have new strategies to treat leg length differences. So that was the first on that leg length discrepancy. Next one I was going to talk about was tibial dysplasia, or bowing of the tibia. This can occur up to 5% of patients with neurofibromatosis. Most of the people who have it, or half the people at least who have it, have neurofibromatosis. And it's pretty rare in the grand scheme of things. So I think if you have this condition, it's worthwhile, as we heard earlier, get a few opinions, get some input, find somebody that's dealt with this problem before. The problem with the tibial bowing is that some percentage of the time it results in a fracture. I'd say our natural history data on this is not perfect, but the ones that we see in clinic in the orthopedic office are the ones that tend to fracture. And once it fractures, it's kind of a real big problem because it's not just the average type of break. You know, the average child will heal a broken tibia in 3-4 weeks. But this is a bad kind of break where the bone there doesn't want to be bone, it wants to be scar tissue and it doesn't want to heal. So this is kind of like the most severe case I've seen, where there really just isn't much of a tibia or a fibula there. We actually did a biopsy to make sure it wasn't a tumor because it looked so terribly severe, but it was an NF patient and they did have tibial dysplasia. Here's a more typical case where we just see kind of a bowed tibia with kind of this sucked candy appearance. That's kind of what we call it in the textbook, food analogies, right? But it's kind of this narrowed, gracile, thin-looking tibia, and the child's up and walking around on it. But as doctors, we know we often see these go on to fracture in the next couple of years, which is something we hate to see. So we'll go home and we'll say, wear a brace till you're done growing, basically, which is a hard thing to say to a family, right? We need to put you in a clamshell brace forever. But until recently, that was kind of really our only treatment for that. Here's the brace, and oftentimes it's even a heavier duty brace than this. It's a whole nother plate across the front that basically functions as a cast for the child. But if we can prevent that fracture, and the fracture in some instances are kind of limb-threatening fractures where it's really hard to get it to heal, we think the brace is worth it. So here's kind of what later down the road, once it's fractured, and frequently we'll see patients didn't know they had the bowing, didn't know they had the tibial dysplasia, local doctor didn't know they had the tibial dysplasia, and they've been in a cast already for 3 months by the time they get to us, and the referral is, why doesn't the bone heal? And then we say, well, this was a dysplastic tibia, and now it's become congenital pseudarthrosis. Here's an older child as well. So at this point, you're going to need fairly significant orthopedic surgery to get this thing to heal. Historically, we had pretty high failure rate at getting it to heal, but I think in modern times we have new additives mechanisms that seem to help quite a bit. So for sure, we're going to do some type of metal fixation to hold the two ends of the bone together, bone-like stability in order to heal. There's descriptions of using an external fixator or kind of building a metal frame around the leg and pushing the two ends of the bone together to get them to heal, bone graft from the pelvis, free fibula, where you take a bone from the other leg and connect the blood vessels and hook it up on the other side. So all kinds of things have been tried. And again, since the numbers are so small and it's such a rare condition, we don't have like super good data about what to do. But I'd say this is kind of the closest to the cookbook that we have nowadays, where we're trying to get the fibula and the tibia to heal together. We're putting in really rigid fixation. We're including bone graft from the pelvis. And in most instances, we're using something called bone morphogenic protein, which is off-label, not FDA approved for this purpose, but it's been used with fairly high success rates around the country. The concern with the bone morphogenic protein is it can cause tumors, which in people with NF is maybe not our first choice. But I think most orthopedic surgeons view that once you get to this point with a fracture and a tibial pseudarthrosis, this is kind of a limb-threatening condition as well. And of course, we have a discussion with the family, do you want to use the BMP or not? Basically, it's just a topical additive that we put in the tibia bone at the time of the surgery. And then in addition to that, we have colleagues kind of in New Zealand and Australia who piloted bisphosphonates. So at least at my center, this is what we're doing. We're doing preoperative IV bisphosphonates that kind of stimulate and prevent excessive resorption of the bone after the surgery. We're using a solid rod or a telescoping rod. We're plating it on addition to the rod. We're using bone from the pelvis. We're using BMP, and we put a big plate on there, and then you're in a cast for 3 to 6 months and then back into that brace. So quite a bit. But if we can get it to heal, I think people have fairly reasonable quality of life. And this next thing is a little bit more exciting. Here's a series again about using BMP. And as we were discussing prior to this, there was a big Department of Defense trial where we tried to enroll patients to be randomized to the BMP versus no BMP. And we weren't really able to get enough momentum among patients and families to enroll patients in that trial. So I think that's kind of a take-home lesson for all the researchers and doctors and scientists here today, that sometimes we have, oh, this would be a great idea. Oh, this would be a great trial, but we really need to talk to families and patients and see what the appetite is for enrollment before we, go out and attempt some trial that's not actually feasible. So I first learned about this approach at Minnesota Orthopedic Society meeting where I heard Mark Dahl talk, and he's a surgeon in the Twin Cities. It's very, very creative. Like weekends, he goes home and he actually like pours bronze sculptures in his backyards of like, busts of historic figures. I mean, really kind of this extra creative kind of person. And he's been very creative with surgical practice. And I'm not that creative. I like to go around all the centers and I learn about all the new stuff. And then if I see promising data, then I'm willing to do new things. But if I don't see that promising data, I'm kind of like, I don't want to be the first in the world to try something, But so I've had a couple patients I've treated with this, I think 7 now. If you can catch the tibial bowing in a patient with neurofibromatosis, the concept is we're going to use those little guided growth plates to straighten the leg, and then you can get out of the brace and not fracture. That's the concept. And I think we have some pretty good data now to support it. So here's a 9-month-old who came in with tibial bowing. Again, we're going to trick the growth plate. We do this often in orthopedics where we take a biologic or a genetic problem and we treat it with metal. So we put our little plates on. This child has a skeletal dysplasia, like a dwarfism, and we've grown the leg straight and we trick that growth plate. That's the growth plate. So, so in this case, we put a little plate in and we're going to kind of pinch the growth plate on the long side. The difference with this surgery, it's a 9-month-old, and usually we do this in like 5 to 7-year-olds. So it's a little bit smaller anatomy. And then as time goes by, we're causing the leg to straighten. So we're going to try and get the bottom growth plate here parallel to the top growth plate up there. So we're 4 months, and the pins are spreading apart. And now that screw now is starting to touch the growth plate, which we don't want. Because if you leave a screw going across the growth plate, it's going to shut down the growth plate and cause a bigger problem, right? So we got to go back in there, move the screw, readjust the plate. That's one reason we do this surgery in 5 to 7-year-olds, because they don't grow as fast and you only have to do it once. In a 9-month-old, I mean, it's like the most rapid period of growth other than fetal life. So you really have to kind of keep an eye on this and make sure you're adjusting that plate as frequently as you need to. But heck, the leg is looking straighter, right? Woohoo! And then we made it another 9-10 months down the road. And now at this point, that line between the growth plate at the top and the bottom are now parallel. So we're going to take out the plate and wean out of the brace and watch and wait. And so even though there's a little bit of residual bowing there, it sure looks biomechanically a lot more stable than we started. And here we are at 3.5. And here we are at 5 years. And I have kind of weaned the children out of the brace over the process of 12 to 18 months after getting the leg straight and taking out all the hardware. So now, would I be thrilled if this young gentleman decided to take up like motocross? I think I'd rather he do like basketball or bowling or something a little lower impact, but I guess time will tell. So this is the first case report actually was from Ireland, from a gentleman who was the fellow of Mark Dahl in Minneapolis. And then Mark Dahl finally wrote it up and got it published. He had 10 patients, 5-year follow-up, no fractures. All of them are out of the brace now. So big improvement, right? So if we can find it early, these surgeries are little outpatient surgeries, no cast, up walking within a day or two, compared to the other huge surgeries where we're taking bone from your pelvis and the kids are in a cast for 6 months. So I think this is super exciting, and I would love to study this technology. And if we can figure out a feasible study to do, I'm happy to help. And I am trying to convince my colleagues around the US to do this procedure. But peds ortho, we're kind of conservative. Like we do surgeries that were invented 40 and 50 years ago and never question it. So it does take a little bit to get peds ortho to start trying new things. So early diagnosis is awesome. We don't always have that luxury. If there is a fracture, we're talking about kind of fairly aggressive surgical management, try and get the thing healed. Unfortunately, even after you get it healed, there is a fairly high refracture rate. So even after that big reconstructive surgery with the plates, we're still typically putting the kids back in a brace, at least till they get to be an adult, at which point the growth plates are closed and we can put in a big heavy duty solid metal rod, like what you or I would get if we were in a car wreck, big heavy duty 8mm titanium rod. You can't do that in kids. So any tibia, bowing, leg length discrepancy questions? You want to take a break? I'm going to dive into scoliosis. Yeah, go ahead. It's a miracle of God. It's all about mechanics. You know, math, physics, biology is not as far. Well, I'm a physics major. Mechanical stress is really critical for the skeleton. And there's actually cells in the skeleton that are mechanoreceptors. So once you get bad stress away from an area, those little osteocytes will actually build new bone. So there's enough bone in there to really stimulate some kind of good biological response from my plates and screws. I'm sorry. Well, I mean, it's true. I'm sorry we didn't say it, but it is. It has a black box warning for children under age 18.
So now that he's had this, oh, thank you. Um, so now that he's healing, weight bearing, you know, obviously low impact, but still just like walking. Do we see that increased bone density in those lesions in children who've had this?
It's just like a very dangerous lesion, right? I mean, historically, there was a pretty high amputation rate. Even without the amputation, often the kids go through 2 or 3 rounds of surgery.
Yeah.
So I guess, and again, it's one of these things where we don't have like a perfect formula. It's not like breast cancer where we have a trial with 800 people and we tried A versus B. I mean, a lot of this is kind of like artisanal. Oh, no, again, like pouring a bronze statue in your backyard kind of work where the peds ortho, I mean, you just have to kind of get along with your surgeon and stay the course.
That was abundantly clear when we were going through the decision making, is that there is no really good consensus. So, but thank you. The biggest question I had was the bone density question and weight bearing.
I would say BMP, you know, I mean, I think everyone in the US right now is using BMP, and that's why that Department of Defense study with no BMP just didn't go anywhere.
You know how long it's been? I don't know how long it's been in use, and if they're showing any evidence of increased tumor growth in this
at least since 2010.
Okay.
And I don't think we've actually seen tumor growth with it. We haven't seen it. It's like a theoretical risk. Theoretical risk of tumor growth.
The voice is at a low roar now. Thank you.
Yes, I went. We don't really know for sure that it's bad in NS. It's been used extensively, like pretty much every adult spine surgery that's major in the US, they are using BMP. So I mean, there's been thousands and thousands and thousands of people that have had it. But again, you hate to do harm, right? That's our goal, not to do harm. So that's the downside of it. But I think for this condition, it's a limb-threatening condition.
There were no good answers. So thank you.
That's what we're all doing. Good luck. Good luck. But your child's walking?
Yeah.
Yay. That's good. That's good. That's good. No, it's hard. I mean, I just see you guys a couple times a year and you live it every single day. It's a lot. All right. Oh yeah, go ahead.
Check 1 2. All right. So I was just gonna say that my wife Brittany and I have a son, Tristan. He has NF1 tibial bowing, and we actually we went through the making connections here. Look at this. This is good. So and actually went through the procedure Dr. Larson had led, and we had started out with a 36-degree bow, and his tibia went down to about 13 degrees, I believe, is where we're at. And so very successful, very non-invasive. Like you said, our son was up moving around the day of surgery, and the fact that that's something, the pain really wasn't that big of a deal for him. So I guess I just want to say that this works. We're very pleased with it. And you know, we were initially told that 50% of fractures, you know, end up in a amputation initially, which that data has now been changed. That's way out of date. so the fact that this gave us a lot of hope and a lot of change in the quality of life for our son. So I just want to say, woo woo, it works. So thank you.
And I think CTF and the networking, I mean, as far as the better treatment for the tibial dysplasia, I mean, a lot of that has been work of this group. So I mean, congratulations. So again, I love to talk about scoliosis, so I'm just going to hold myself short here. But I do a lot on scoliosis. About a third of people with NF have scoliosis. But doctors, like the jargon we use is Cobb angle. So it's like how tilted are the vertebrae, how bad is the scoliosis? But really it's more of a three-dimensional problem. Bracing we think works for some people around 20 to 40 degrees, and then over 50 we think we need surgery. Doctors are supposed to be checking for scoliosis. I mean, I think if your child has NF, hopefully they're being checked once a year clinically. They don't need an x-ray once a year, but clinically being checked for scoliosis. But it's hard to see when the kid's standing up, it's hard to see. So they lean down, they touch their knees, and you see the rib prominence. That's kind of more common. Here's that rib prominence again. In the lumbar spine, it can be again kind of a rib prominence. And this old fashioned thing called the scoliometer I still use, but in clinic, if you have a tilt, then we get an x-ray. That's kind of our guidepost. So, and depending on how much growth the child has, that's what is correlated with the risk of progression. So if you're very young, you're diagnosed with scoliosis, a 3-year-old is going to grow for 13 years. We've got 13 years of watching that scoliosis. If you're 15, nearly done growing, your scoliosis, if it's mild or moderate, should be stable and no treatment is recommended. That being said, we know adults with mild or moderate scoliosis have more back pain. You know, people with NF have more back pain. So, I mean, I think that knowledge is power, and maybe do what you can to help your back as far as not smoking, maintaining a healthy body weight, keeping your core strong. It's not a bad piece of advice for all of us, really. We can assess growth either on the pelvis. So on the x-ray of the spine, we can see the pelvis. That helps us know about growth. More and more so, we're doing it based on hand bone age. And actually, there's normative charts for children without NF regarding hand bone age, curve magnitude, risk of curve progression. And that would be cool to develop that for NF too. So we have a sense of who's gonna progress and who needs treatment. But basically, the teenage years are bad. We know that for lots of reasons. They're bad psychologically, they're bad for scoliosis. So they hit this big growth spurt and the curves get worse in their teenage years. And then we know if the curve is really big and you're done growing, they're also bad, because if you have a fairly large curve, it can get worse as you continue through your adult years and continue to have more and more problems. So here's a patient, not with NF, but 30-year follow-up, and she had a fairly large curve at age 20, and now over the next 30 years, it's gotten worse. So our definite guidelines are usually bracing 20 to 40 and over 50, some type of surgery, typically fusion. So how does this apply to NF? So there's kind of two flavors of NF scoliosis, and we call it non-dystrophic is scoliosis that behaves like regular scoliosis. And then there's another flavor called dystrophic, which is much more aggressive, presents at a younger age. The curves get worse rapidly. Bracing doesn't work as well. The etiology of like, why does this happen? I think it's unknown. Sometimes the dystrophic scoliosis is associated with a plexiform neurofibroma. Sometimes it's associated with dural ectasia, where there's too much cerebral spinal fluid that's kind of eating away at the bone. But for sure, this dystrophic scoliosis, you need to watch for it. And if you find it, it typically needs fairly aggressive treatments to prevent it from getting quite severe, to the point where it can, pinch on nerves, cause paralysis, do bad things. So there's X-ray features that are associated with the dystrophic form, and basically it's watching the bone being eroded away, because if the bone is being eroded away, it's a more kind of aggressive form of scoliosis. But we'll see sharp angular curve patterns. We'll see ribs kind of migrating into the spinal canal. We'll see bone loss again. Again, typically all these vertebrae would be nice and square. But because of the dural ectasia, which is all this extra cerebral spinal fluid, that bone is being eroded away, and it's much, much smaller. And it makes it harder for us to do the surgery because there's less bone to work with. It's kind of like that tibial dysplasia problem. There's less bone to work with. The bone that's there doesn't want to heal, and it makes our typical surgical strategies more challenging. The bone doesn't behave the way that it usually would in a child. So if you do have a dystrophic curve with features that look like dystrophism on X-ray or MRI, higher chance that child's going to go on to need surgical management. And if you are managing it surgically, again, in my hands, I like to use navigation because a lot of times the anatomy can be really atypical. So, I skipped a pedicle screw here, and that's because I navigated. And during the surgery, I could look down there and see that there really isn't a little bony channel to put the screw in. The screw goes in through this little spot here. And that's like a little 2 mm spot, and the biggest screw, the smallest screw is 4 mm. So, I think either the preoperative imaging, so a lot of people say, I don't want a CT, but if you have scoliosis, if you have NF, if you're having a surgery for your spine, a pre-op CT is probably medically necessary to understand what the anatomy is and what there is to work with so your surgeon doesn't have any surprises. And then again, there's that tiny little pedicle. So I bring in the dreaded CT scanner during the surgery. I turn the button down, 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 down. And then that helps us place the screws in exactly the right spot to get the best fixation to hopefully get the bone to heal and to avoid having a second surgery. So occasionally we'll see really severe patterns. It could have gone from a normal looking curve to this in like 18 to 24 months. So you can see really quick progression. And once it becomes more severe, you're going to need more surgery to deal with it. So it might be 2 surgeries instead of 1. It might be admitted to the hospital for traction in order to then do the surgery after the patient has had time to stretch out the bone, stretch out their nerves, and be able to tolerate, the kind of surgery that's needed to correct a more severe deformity. So here's a patient we treated more recently. I followed her age 5, no scoliosis, don't worry about it. Age 6, moderate scoliosis. Age 7, we're going to try a brace. And from 8 to 9, you can see I just really kind of totally took off. And at this point, I'm like, this is probably dystrophic. So I think historically we would have done a fusion surgery at this point in a 9-year-old because we know the scoliosis is aggressive and we want to avoid, having a big, terrible deformity a year or 2 down the road. More and more so under age 10, we're using growing rods. So we had a conversation with the family and said, do you want to do growing rods and have 2 surgeries instead of 1, but allow her spine to grow taller? Because basically once you have a fusion, your spine doesn't grow anymore and you have a short trunk. So this family said we want her to be taller and we want to do a growing rod, which we successfully did. I'd say this is slightly controversial in neurofibromatosis, whether you just do a fusion or whether you try growing rods, particularly for a 9-year-old. Like a 3-year-old, you have to do the growing rods, right? You can't really fuse a 3-year-old's back, but if you're at 9, I think there's some wiggle room and discussion, and I was hoping that was another thing we could talk about today. Okay, oops, sorry, I do have a surgical picture. So anyone who wants to avert their eyes, avert your eyes, okay, surgical picture. So this is how you pass the growing rod. So you kind of do it through 2 incisions and you can pass the rod underneath the skin. And these particular growing rods have a magnet in them. So the child can come back to clinic and instead of needing surgery 2 times a year to lengthen the rod in surgery, we can lengthen them in clinic with this magnetic actuator, which has been great because nobody wants their child to have surgery twice a year for 5 years. We've been using these magnetic actuators. And here she is. We're 18 months post-op. She's growing taller. She's coming back to clinic. It's working pretty well. Now we're 3.5 years in. These rods are supposed to deploy 4 centimeters, but really on average, we're getting more like 2 to 3 centimeters out of these rods because basically they get stiff, they get worn out. It's an uncommon medical device and it's working okay, but it's not perfect. But we were able to grow her spine about a total of 4.5 centimeters. And she's doing well. Her overall chest height, we got higher from the final fusion. We took these rods out, put in new solid rods. We got a total of 6 centimeters, so 2 inches taller of chest height. Is it worth it? I don't know. 2 surgeries instead of 1. Again, I'm really about what do the families want and let's have a discussion. What's our best approach? Some centers aren't doing these magnetic rods for children with NF because you can't get a very good MRI with the rods in place. So I have colleagues around the US that say we don't do this for NF because we need to be able to get an MRI. And I'll show you what the MRI looks like. It doesn't look too good. There's a lot of discussion in the literature, like what's the role for these magnetic growing rods? When should we use them? Are they worth it? They cost $17,000 each, so they're kind of expensive. It takes 3 years for them to become cost neutral just from the hospital perspective. And then this other abstract my friend just published showed half of them quit working after 3 years. So it's expensive for society, but it does provide children with opportunity for growth. And I think for the right NF patient, they're appropriate. One other more surgical picture here, watch out. But the other problem, we do have to take them out. You don't want to leave them in there forever because they kind of have a fair amount of metallosis. So there's like metallic material from the rod and the magnet that spread into the soft tissue. So you wouldn't want to leave them in there forever. And we've done some research on it. Again, it's maybe similar to the BMP for congenital pseudarthrosis of the tibia. We don't know that it does anything bad, but it's enough to make you just at least pause and think about it. And at least in my hands, I'm always taking these out, even in a severe neuromuscular patient where I'm always taking out the magnetic rods after we're done with them. We did some histology and there's little chunks of metal in the cells that probably go away once we're done. But there's a little bit of a macrophage response or a little bit of immune response locally. But the bigger issue, I think, for NF is all this artifact. So on the left is kind of a normal MRI where you can see the spinal cord. And on the right is my poor medical geneticist tried to get a screening MRI with the magnetic rods in place without talking to me. And you can see they didn't get to see very much of the spine, right? It's all because the MRI is a magnet and the rod is a magnet. So the two magnets together make this huge metal artifact. So I'd say in many instances for NF, bracing is very successful. I mean, so brace, 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 and then one fusion after age 10. I mean, I think that's a very successful pathway if you're controlling the scoliosis. This is a child I never thought would be able to wear a brace, but she wore a brace for 7 years, and we controlled her scoliosis, and then we did a fusion, and she was very happy to get out of her brace. But that's another route rather than the surgical route. And I think every family has to kind of find their path. Growth friendly is more surgery. Fusion, you end up being probably a little bit shorter, but you get more correction at the time of the final surgery with the fusion. Again, as far as how much spine height, if you start the growing rods earlier enough, you can get more height, but you get less correction. There is some natural history data, and really kind of at the end of the day, we want your cob angle to be less than 70 degrees. You want your back not to be too rotated. You want your back to be more rounded than flat. And then both the spine height and the residual curvature are important for as far as getting good pulmonary function in adulthood. So I think in summary, 30 to up to 30% of NF patients may have scoliosis. I think the non-aggressive form, it's fine to try bracing. If you have the aggressive form, it's probably the x-ray is looking bad by the time you've tried the brace, and early surgical management will be indicated. You probably want to get some opinions if the child's under age 10, whether they're a candidate for growing rods or not. Sometimes when there's a lot of rounding front to back, we just can't make the growing rods work. There's not a pathway forward with growing rods. But in general, for the dystrophic curves, you do want early surgery. You want to get to it before you have a neurologic deficit and probably go to an experience center. I do have a couple minutes on medical radiation. I'm just going to keep plowing ahead because every time I'm in a group like this, people ask me, what about all those x-rays and what about the CTs? And it's really terrible. And I'm like, yes, but on the other hand, it was terrible being an orthopedic surgeon in 1840 when we couldn't see what we were doing. So the imaging is wonderful, and there's been massive amounts of improvements in the last 30 years as far as lowering the dose of radiation. But radiation, again, is basically light. It's high energy light. It's photons, and if the photons are high energy enough, when they hit the DNA, they can cause DNA damage. And the concern specifically with NF is that there's already predisposition to tumors, and if you're radiating tissues that are already predisposed to tumor, is that risky? Again, I don't think there's a specific study showing that, to my knowledge, but it's a theoretical concern. You know of a study? Whole different ball, yeah. And have a little bit. So cancer treatment, that's like 100 millisieverts, right? That's a lot. 20, the federal government allows you to work in a nuclear power plant and get 20 millisieverts a year. That's quite a lot. I wouldn't want that. But they let you set up a nuclear power plant in a small town, and the whole city gets 1 millisievert a year without anything, right? Crazy. So about all of us get about 6 millisieverts a year on average. Half of that's medical radiation, and the other half is kind of atmospheric radon in your basement, background radiation. There are studies. This is a recent one. So 16 millisieverts in young ladies with scoliosis resulted in a higher rate of cancer 20 years later. So maybe as little as 16 can do bad things. There are some very fancy x-ray machines out there. This is kind of like $1 million x-ray machine, but there's over 80 of them in the US. And it cuts the radiation dose by about 80 times. So the x-ray is 1/80th the dose as a regular scoliosis x-ray. And we studied this at our center. Again, you save 3 millisieverts over the entire course of treatment, which is like 1 year annual background radiation. Or if you get this fancy microdose, it's like a 94% reduction in your total radiation over the course of scoliosis care. The other easy thing you can do if it's you or your child is just don't face the beam. So if they're shooting an x-ray and they're shooting it at you, it's going to get your thyroid, it's going to get your breasts, it's going to get your gonads if you're a male. So back to the beam cuts the dose by like 40 to 50%, just that one little step. Doesn't matter what the beam is. If you are using CT or intraoperative CT, ask for a low dose protocol. So, I go around the US and I tell everybody, please turn the button down on the machine. And we've studied it extensively. You can get a good quality scan, just crank that button down. And if you're looking at bone, you'll do just fine. At our center, we took the manufacturer dose for a spine case, which was 13 millisieverts, and we dropped it down to 0.82, which is 1/6 annual background radiation by just turning down the dial, which is about the same as fluoroscopy, which is what most centers in the US use. So our CT navigated protocol is the same as fluoroscopy. Don't get side views and don't get hard copy x-rays. So if you go to like a small shop doctor office and they have a film, that's a bad sign. That's like 5 times more radiation than something that's digital. So always kind of seek out digital radiography. Don't go and get like 18 crazy x-rays from your chiropractor of views that don't really exist, or these oblique views are very high radiation. So a 4-view lower back series is the same as a low dose CT of the lumbar spine. It gives you a lot more information than the x-ray. And then finally, I'd say, again, if you're undergoing cancer treatment, you need a bone scan. If you have a major oncologic problem, you might need a bone scan. But for bone scans for stress fractures, bone scans for chronic pain, I'd try to avoid it. Bone scans are pretty high dose, and bone scans go to the ovaries and the bladder and kidneys and places you don't want to be irradiated, really. So here's my summary thing. Talk to your doctor about any imaging you order. I think you could be an informed consumer. They should be comfortable talking about it. Hands, feet, knees, ankles, all that is super low dose. It's like pelvis, brain, hip, spine. That's the higher dose stuff. CT is higher dose than x-ray. There are some fancy x-ray machines out there now that really cut the dose by a huge amount. And then when in doubt, just don't face the beam. It's best to face away from the beam. And then at the end of the day, you kind of need some of these studies. We're trying to treat conditions. We're trying to do the best we have. All major medical centers have a radiation physicist that goes around and measures all the machines. And I think in the US, in Canada, we're spending a lot of time trying to do our best as far as avoiding excessive radiation. So thanks.
Most, if not all,
You can share this.
most, if not all, pediatric hospitals. There's been a national what you call gently, where they've all been lowering the doses of all the different radiographic studies. MRIs don't have any radiation. So I think if you go to a children's hospital, you're pretty safe to know that you've got the lowest dose of radiation. Let me take go on.
Yeah, agreed. I'd recommend Children's Hospital because they're paying attention to it. If you
Right.
just take your 3-year-old to the adult hospital down the road, you may not get the same
Absolutely. So my first question is about MRI scans. Do you get MRI scans on every child with scoliosis before you at the time of diagnosis, looking primarily for adjacent plexiform neurofibromas?
We will get it for sure before surgery, absolutely before surgery. And then beyond that, I kind of defer to Dr. Babovic. And I did call Dr. Babovic, our medical geneticist, on the phone before I came. And she said, certain patients who have a known plexiform neurofibroma do need periodic MRI screening. But it doesn't have to be every patient every year for an MRI.
Yeah.
And I think this practice maybe varies by center.
It is, but I will say that my impression, and I don't know whether it's been documented, the children who have dystrophic scoliosis, so that they're present at birth and the bones are abnormal, they quite commonly have a plexiform neurofibroma near a paraspinal, get next to the spine, and that needs to be monitored because I'm sure many of you know those malignant peripheral nerve sheath tumors, MPNSTs can arise from them. I've had the experience to have had several kids who've had dystrophic scoliosis and plexiform neurofibromas where they have not been monitored or they were never found beforehand. So it's important to keep that in mind. And surgery, you need surgery, but you also need to monitor those tumors as well.
And I think I do have friends that say, they can't put in the magnetic rods because of that plexiform neurofibroma. But the alternative really is surgery twice a year. So I mean, I
Right.
think the other alternatives that we can just take, if they need an MRI, we can just take those magnetic rods out and stick in the traditional ones. And it's less than we would have done with traditional groin rods.
So here's a common question that I get is for scoliosis, is chiropractic care helpful?
I think it hasn't been well studied. I mean, there are a lot of chiropractors in the US, and as far as a low cost way to treat adult back pain, which is ubiquitous, right? 88% of adults miss a day of work due to back pain. So, I mean, there certainly is a role for chiropractors. I'm not certain what they do. So it's a little bit like bringing me the stack of their documentation in German, like the words that they put in their chart, I don't understand. So I guess I'm neutral. I'm neutral on chiropractic care.
Okay. If a child has tibial bowing, does that increase the likeliness of developing scoliosis?
I have not seen an association between the two, but there was an interesting PowerPoint I took a picture of from Stanford that had kind of some phenotype associations earlier today.
Yeah, I'm not aware of the association either. Let's see so here's something you didn't talk about, pectus excavatum. My 11-year-old daughter with NF1 and scoliosis, and maybe you'll explain what pectus excavatum. We have been told that the surgery to correct the pectus is purely cosmetic. Have you ever seen a case of pectus excavatum? And have you seen a correlation between pectus and NF?
For sure, scoliosis and pectus go together. There's a much higher rate of pectus in people with scoliosis, and it has something to do with chest wall development and connective tissue. I don't know of a pectus and NF association.
Oh, no, there is, particularly I mean, I think one of the speakers earlier today alluded to Noonan syndrome. There are several mutations of the NF1 gene that make the child have some some characteristics of Noonan syndrome, heart disease, a little difference in how the eyes are shaped, and pectus excavatum for sure.
Pectus is a divot. So there's kind of a divot in your chest. And sometimes we call it the double crush phenomenon. If you have scoliosis plus pectus, it's now two skeletal features that are pushing on your lungs that shouldn't be, so having both at once requires a little bit of care. If the person has a lot of kyphosis and you correct the kyphosis, it can make the breathing and the chest compression with the pectus worse. So I would say pectus can cause symptoms. It can cause fatigue, respiratory differences. There's very specific criteria for treatment, and the pediatric surgeons actually treat pectus.
Yep, and I would say in the absence of scoliosis in the non-NF child, my sense is that it's primarily in most cases a cosmetic issue, but not always, but primarily without scoliosis or other medical conditions, it's primarily cosmetic.
It's, I think, a little debated too, depending who you talk to,
Right.
because people say that about scoliosis, but if you have severe scoliosis, it's not cosmetic.
No,
If you have severe pectus, it's not cosmetic.
Actually,
So
I've never
where's
heard-
that gray zone?
I've never heard anybody say that about scoliosis because back pain, and really you get that a lot.
We talk about it among ourselves
Got
for
it.
the mild ones, like San Diego and California. They use children with smaller curves.
So do you guys have more questions? Because I think that's what I see.
Oh, go ahead. Yeah.
actually has more to do with radiation safety. And I didn't see, and I was surprised, lead draping, just using lead drapes in order to limit the exposure to what you're trying to x-ray.
It's hard because it's hard to put the lead in exactly the right spot, particularly on little kids. And then again, if you're shooting the x-ray the wrong way, it can double your exposure. I mean, you'd hope you get the lead between the beam and you, but there actually hasn't, and I've talked about the specific point with my medical physicist, there hasn't been a study that the lead shielding actually results in lower absorbed organ dose. Because again, you're in a box, the x-ray beam's coming through, it's like a mirror, so that beam is bouncing all over the room. It's a little unclear, but I think lead shielding, again, better safe than sorry. And then one last question from the back.
Yeah, same topic with the radiation safety. The fancier machine you showed, we have one at my pediatric hospital in Halifax. Is it common, like part of the reason it's safer, is it because it does both views at the same time? It's just a better machine.
It's a totally different technology. So again, like X-ray starts from a single source and spreads out. And this is a slot scanner. So it's sending a very tiny little beam and you have to stand still and it goes for 8 seconds. So, and then the absorption behind has like copper filter. It's just a fancier unit and not very multi-purpose. Like all it does is legs and spine. And so most centers, if you're not a ped center, they don't have one.
One more question. My son had surgical repair for tibial dysplasia in March. He is forming new bone, but it's going slowly. What is the average time for healing from for tibial dysplasia in NF versus normal bone healing?
Yeah, again,
When
kinda-
do we need to start getting concerned?
Yeah, kind of 3 weeks for a normal bone will heal, 3 to 6 weeks for a child. And then the tibial dysplasia is 3 to 6 months, 2 years, really. I think 2 years. I mean, if you're doing a study, you'd want a minimum 2-year outcome to know that it actually healed. Thank you, everybody.
Thank you very much, everybody.